Okay, so will this work now? Oh, okay, good. So here are the three main themes for my talk this morning. Number one, I'm going to spend a fair amount of time on conceptualizing just what we mean by genetic privacy. Number two, I want to discuss the issue that Pat alluded to, and that is genetic exceptionalism. Should we consider genetic information separately and distinctly and as being unique? And third, I want to explore the effects on privacy of some specific new technologies. So let's begin by talking about genetic privacy. And to begin talking about genetic privacy, you need to talk about privacy in general first. And I found that privacy is a befuddling concept. If I ask the people in this room, can you tell me what informed consent is? Everyone could, in a sentence, describe what informed consent is. If I ask you to describe what privacy is, you would need a page, not a sentence, and no two pages in this room would be the same. And it's a concept that's really hard sometimes to get your hands around. Privacy is like motherhood and apple pie. I'd like a show of hands of people here who are opposed to the concept of privacy. Okay, so nobody's opposed to privacy in the abstract, but that's as far as the agreement goes. There's widespread disagreement whenever you get to specifics, such as, well, how do you define it? How do you compare the worth of privacy versus other important interests? And how should we protect privacy if you think it's important? When you get to the subset of privacy called health privacy, it's especially befuddling, including for those who work in healthcare, and for some healthcare types it's even more befuddling, or they might be befuddled on a permanent basis. So let's start with my definition of privacy that I'm going to use throughout the talk, and that is privacy is the condition of limited access to the person or personal information. And this definition has privacy in two different aspects. The first is intrusional privacy, which can be where your physical space is invaded, where you're being overheard or overseen, where your phone is being tapped, etc. And the second is informational privacy. And there are many different kinds of information that we might consider as candidates for protection. And so some examples would be educational information or financial information, or what we're going to be talking about, health information. So health information is a subset of information, and health information privacy is a subset of that. Well, informational health privacy, then we can subdivide even further, and there are many different kinds of health information that we might have, and some examples would be behavioral health information or reproductive health information or genetic information. So this is a diagram of where we've come so far in a very short period of time. I said, let's break privacy down into these two main components, informational and intrusional, and let's concentrate on the informational branch. And within informational privacy, there are many different kinds, and the three examples I used, educational, financial, and health. So we're concerned about health. Now within health, there are many different kinds of health information, and some examples would be behavioral, genetic, or reproductive. And so our concern for this morning is this sort of level, genetic under health in the informational health privacy branch. Now, what I've given you is a sort of a simplified, quite simplified scheme, and I want to talk about some things that are not in this diagram. First is what is sometimes called decisional privacy. Many times you hear about reproductive or procreative liberty, as being a privacy right. Well, that is, in essence, an autonomy right, which may or may not be under the scheme that I've created. It's the ability of individuals to decide on their course of medical care or health care. And then there's another aspect, sometimes called proprietary privacy, where your name is used without your permission or consent, or your information is used without your permission or consent, and this sometimes goes under the name of appropriation. Now, these are other aspects of privacy, but outside of the narrow scheme that I want to create for you. I also think it's important to distinguish informational privacy from two related concepts that sometimes are misused or confused, and they are confidentiality and security. So informational privacy, as I want to set it up, is a two-party relationship between an individual, any one of us, and any other party. It's the sharing of information of any kind from the individual to somebody else. Now, it could be implicated when the somebody else gets the information without the consent of the individual, or it could be the voluntary sharing of information by the individual with some other groups. Privacy, informational privacy, goes to whether this A, any one of us, has the ability to keep from others certain information. And if one has that ability, we say there's a state of privacy that exists. By contrast, instead of a two-party relationship, confidentiality really is a three-party relationship. And here in the healthcare context, A is going to be a patient, A shares information with a physician, and now confidentiality, all the way back to the time of Hippocrates, deals with a situation of under what circumstance can a physician then redisclose information to somebody else that was shared within the confines of a confidential relationship. So if I say, listen, I want to tell you something in confidence, even in the sort of the colloquial meaning of the term, if I tell you something in confidence, the assumption is you're not going to redisclose that information without my permission or approval. Now, this model has proven to be very troubling for policymakers, because if you're worried about patient information getting to see some third party, the focus has been on this point here. So many laws have been in place saying, okay, physicians can't disclose information with any of these people without the permission of the individual, without their consent. But of course, if you want to apply for, let's say, a life insurance policy or a job, the employer says to you, sign this release, sign this authorization for the physician to disclose that information. And if you passed a law that said physicians can't disclose information, or physicians can't disclose information to anyone other than a patient, it's still not a problem, because the insurer or the employer says, well, you have a right to your medical records, go get them from your physician and mail them to me, or send them to me electronically. And if you passed a law that says you can't use clinically based records for any non-clinical purpose, then C is going to come in and say, okay, I can't use your records. You want this life insurance policy, come in Monday morning at 9 o'clock and we're going to go over you from head to toe. So confidentiality means more than just how you control this information. In the larger sense, it's when does someone who's not the patient have the right legally or the ability to gain access to that information. And it's not a procedural right or a procedural method of dealing with information. It's a substantive method. What right does an insurer have to health information? What right does an employer have to personal information? And you can see it gets quite complicated very easily. The easiest one is security of the three. And the quick definition of security is that you want to keep unauthorized people from gaining access to information and permit authorized people to get access to information. That's the simplified version. Conceptually, security is the easiest of the three. I'm not going to pretend that technically it's necessarily the easiest of the three, but at least conceptually it's the easiest of the three. I also want to see if I can distinguish this morning privacy from the right to privacy. And these are also terms that are often, in my judgment, mangled and used incorrectly and perhaps interchangeably when they shouldn't be used. So I want to set out three different conditions. So the first one, privacy simpliciter, which I've been talking about, is the objective sense. When is there a state of privacy that exists? And I want to contrast that with the second, the right to privacy in the normative sense, and third, the right to privacy in the legal sense. And I don't think these are quite the same, and I hope I can convince you of that. So we've talked about the first one, objective sense privacy, a condition of limited access to the person or personal information. But what about the second one, the right to privacy in the normative sense? This considers ethics, morality, philosophy, and policy, and some of the arguments in favor of having a right to privacy in a normative sense are that privacy promotes human dignity. Privacy permits the development of intimate relationships. And privacy enables medical care. It's hard to conceive of traditional medical care and physician-patient relationships without the fundamental concept of privacy and confidentiality as well. So the conclusion for this part has to be that privacy ought to be protected to advance important individual and societal interests. Now, we can talk about to what degree and how and so on, but that's the normative principle. In terms of the legal sense of the right to privacy, there are different subparts based on the kind of law that we're applying. So if you're talking about constitutional law, and one aspect being unreasonable search and seizure, under Canadian and US law, the Charter of Rights and Freedoms, or the Fourth Amendment to the US Constitution, it's prohibited. So that's the constitutional sense. Then you get the statutory or regulatory sense. So we've got a series of provincial privacy statutes, and in the United States, the Health Insurance Portability and Accountability Act's privacy rule, something that the Americans in the room, I'm sure, know very well and love every line of it. Okay. Then we get to the third sense, the legal sense, is the common law legal sense. And this is a picture of Louis Brandeis. And for those of you who don't know, the law school associated with my university is called the Brandeis School of Law, and Brandeis is actually buried under the front steps of the law school. So we're unofficially required to show a picture of Brandeis in every talk we do. But in 1890, Brandeis and his law partner Samuel Warren wrote a very famous law review article called The Right to Privacy, and in which they set out why it's important for the common law to recognize the right of privacy. Most common law countries have not gone in that route. Most common law countries, and of course civil law countries as well, have gone the statutory route in attempting to protect privacy. But in the US, much of our privacy protection is through the tort of invasion of privacy that was originally proposed in 1890 by Brandeis and Warren, and later, mostly after the Second World War, took greater, became much more popular with the courts. And there are 4 separate common law torts for invasion of privacy that have been recognized in the United States. The first one is unreasonable intrusion upon seclusion, and that of course fits very well with my two-part model as the intrusional aspect of privacy. The second is publicity placing another in a false light, which would be the disclosure of information, and therefore it comes within the informational branch. Third, the public disclosure of embarrassing private facts, another informational branch privacy tort. The fourth is appropriation of another's name or likeness, which is the appropriation tort that I referred to earlier. Breach of confidence was excluded from the restatement of torts when it was developed by Prosser and others, but it's a closely related common law theory. So the conclusion, at least as to the legal part of the right to privacy, is that the legal right to privacy concerns discrete categories of protected interest, and I'm not saying that's the way the world ought to be. I'm just commenting that I think that's a fair statement of the way the world is at the moment. Well, privacy is even more complicated than that, so I need to make a few more additional points. First, privacy has an intrinsic and an instrumental value. Let me see if I can demonstrate that to you in the following way. Suppose, many people are concerned about loss of privacy because they're going to lose their job or they're going to lose some other, in the U.S., health insurance. But there's also an intrinsic value to privacy, including health privacy. So if I said to you, I guarantee you that nothing bad of a tangible nature, you're not going to lose your home or your mortgage or your credit or anything. And so that 1 foot tall stack of health records that I asked you to bring in today to this talk that you have in front of you, now I want all of you to turn to the table next to you and give that stack of records to someone who's sitting there, and they're going to look them over for 48 hours and bring them back. I think some of you might think that's not a good idea, even though no tangible harm will befall you. And so people are concerned about the intrinsic value of privacy. Second point, privacy is certainly not absolute and does not trump other interests. There are other important interests that may overrule privacy in one situation or another. And third, privacy is not free. Privacy is not cheap either. And we have to decide whether we think privacy is worth the cost in various circumstances. Privacy does interfere with research. Some researchers that I know would like to see privacy disappear. Oh, they'd also like to see me disappear, I think. But they would be very happy to see privacy disappear. And some law enforcement people are not too crazy about certain aspects of privacy. And you can see these are other important societal interests. We have an interest in research and law enforcement and public health and so forth. To what degree are we concerned about the relationship between that and privacy? So let me go back now to this diagram that I showed you earlier. And having sketched out at least my views of how privacy is structured, and we'll come back here and note that we said, all right, I'm going to split privacy into 2 branches, informational and intrusional. And informational, I'm going to split into different kinds of information. And under health, we're going to split that into various kinds of informational health privacy, and we're concerned with genetic. So the question is, if we want to protect, to some degree, genetic privacy, do we protect it at this level, which in this diagram would be the 4th level down? Do we focus here? Or do we say, okay, to protect genetic privacy, we need to protect informational health privacy, which includes all these? Or do we need to say, all right, we're going to protect all informational privacy, which would be at this level? Or do we need to say, we're going to protect all privacy, which would include this level? And this is a very important policy debate that is going on in many countries. And it's certainly an issue that we've had to deal with in the United States over the last decade. So that brings me to the second main topic I want to talk about this morning, and that is the issue of genetic exceptionalism. Should we single out this sort of 4th level interest in just genetic informational privacy to be our focus in trying to protect this information? Well, much genetic information is sensitive, but not all genetic information. My eyes are brown, and that is genetic information of sort. I don't consider that to be too sensitive. I'm voluntarily sharing that information with everybody I meet. Other things of a genetic nature I would consider to be more sensitive, and I'm probably not going to share that information. So genetic information could implicate the health of family members. It could be transgenerational in terms of demonstrating the potential that offspring would have that same trait or predisposition. And it often carries stigma and has led to discrimination and even eugenics. And those of us who work in the field, I think, should never lose sight of the fact that eugenics is the original sin of genetics. And we cannot lose touch with the idea that genetic information has been used in the past for all sorts of terrible things. People know that, and we know that, and it's, you know, you don't get credit for good faith if something happens that blows up on your watch. So because genetic information includes sensitive health information, I think most people would agree with the general principle that it should be protected from wrongful access, use, and disclosure, and that privacy, confidentiality, and security measures should be in place. I didn't say what measures. Here's where my personal viewpoint, I guess, started when I said good morning in my personal viewpoint, but on this point, my especially personal viewpoint comes through. And that is that separate genetic-specific legal measures are not desirable and are often counterproductive. And here's how I would make that argument. First of all, I think it's impossible to define genetic. In genetics, the good old days often refer to things that happened last year. On this issue, maybe we can go back 15 or 20 years ago when we used to put disorders into two categories, genetic and non-genetic. And the genetic were all the monogenic single gene disorders, you know, Tay-Sachs disease and CF and Huntington's disease and so forth. And everything else was in this other category. Now we know that there really is only one category, and that many of the so-called environmentally induced disorders have a genetic component. Now the genetic component may vary, and the genetic component may only deal with triggering the mechanism, or it may even deal with the pharmacogenomic side, how do we best treat the disorder, etc. But everything, including trauma, because genetics is going to determine how fast your blood clots and so forth, every disorder has, to some degree, a genetic component. So scientifically, it may be a non-starter to try to define genetic. And then legally, it's impossible. The problem for the law has been, do you include family health history within the definition? If you don't include family health history, you get these ridiculous results, such as the following. Texas enacted a law that prohibited genetic discrimination in employment and insurance, and defined genetic information as the results of a DNA-based test. So that means that it would be lawful in Texas to refuse to hire me because in my medical record it says father died age 50, Huntington's disease. I've never been tested. I'm making all this up. I've never been tested. But based on family history, they know I'm at a 50% risk, and that's a good enough reason not to hire me or insure me. I'm not covered by the statute. Only people who have taken a genetic test. So you got to include family history. Well, if you include family history, what are you leaving out? It's such a large area. when you get individual history and family history, legally it's hard to separate that information. Second, for the informatics folks in the room, you'll know this, it's a nightmare to try to segregate genetic from non-genetic information in health records. It can be done, but nobody's really cared enough to try to do it. It's complicated, but it certainly can be done. And it's part of a larger problem of how do you segment health records by category. And as we go to electronic health records and electronic health record networks in the developed world, every country is wrestling with these issues. How do you sequester certain kinds of information? And it gets complicated. Let me just give you an example. One category that you would say, okay, this is sensitive, we might want to keep this separate, would be mental health information. If we wanted to segregate mental health information, the first impulse would be, okay, we'll go by provider. And so all the psychiatric visits would be coded and be in a separate file. Well, it turns out that most mental health services and diagnoses and discussions and prescriptions are not from a psychologist or a psychiatrist. They're done in primary care settings, where your primary care doc says, well, how's everything going? And you say, well, I'm having trouble sleeping and I'm losing weight because I'm really worried about whatever. So I've got these anxieties, or I've got this and the other thing. And you're going to be treated by your primary care physician, and it may not be coded at all. It may be in free text somewhere. So how do you get a handle on that? It's a complicated issue. So it's hard to segregate that information. And third, I think genetic exceptionalism can be a self-fulfilling prophecy. This genetic stuff is really nasty. We have to have a separate law to protect genetic information. We've got a health law that protects health information, but we've got an extra law for genetic information. That is really wild, dangerous, nasty stuff. Well, if you keep sending that statement out as a matter of public policy, people will regard genetic information as incredibly sensitive and it will be self-perpetuating. It may be the case that as we have more genetic information incorporated into the medical records of the typical person, that some of the stigma will be dissipated, and I hope that's true. But by treating it differently, I think you perpetuate this problem. And the other thing that I should say, I want to talk for a second about U.S. law and how we've managed to screw things up on this issue, is that focusing on genetic information is a way of avoiding more difficult issues. So many people who are at risk of genetic disorders don't want to be tested because they're afraid of the social consequences. And so the U.S. enacted last year a law called the Genetic Information Non-Discrimination Act, or GINA. And GINA makes it unlawful to discriminate in health insurance and employment, none of the other ways that you can be discriminated against, such as long-term care, disability, life insurance, stuff like that, on the basis of genetic information. Well, much was made of this, and it sounds good if you don't think about it, but the law only protects people who are asymptomatic. And once you're symptomatic, you have no protection whatsoever. So if I apply for an individual health insurance policy today, and in my record, maybe I'm genetically predisposed to prostate cancer or Alzheimer's disease or some other disorder. Based on GINA, it would be unlawful to refuse to issue me a policy or to charge me a higher rate based on this genetic information. Well, that sounds pretty good. I'm genetically predisposed to colon cancer, they can't deny me a policy. Well, next year I get colon cancer, right? Well, that would be bad. Does GINA protect me? No. Why? Because now they're not basing it on genetic information as defined in the statute, they're basing it on my medical condition. So the only way an absurd result, right? So the only way that you could prevent this kind of genetic discrimination is to say that people who are already ill from whatever cause have a right of access to health care. And you may be following the fact in the United States that some people disagree over that issue. So this is not a problem that can be solved by just sort of tinkering with a genetic component. When you do that, you may get feel-good legislation that actually does nothing. So genetic exceptionalism, I think, certainly in the United States, is a politically expedient strategy if the choices are do nothing or enact comprehensive measures, and they don't want to do either of those two, so they enact a genetic-specific law, hold a press conference, and everybody's happy, except it doesn't do anything. Okay, the third issue I want to talk about is the effects of privacy on specific technologies, and I'm going to go through several of them. First one is biobanks. And the main difference between biobank-based research and traditional research, I believe, is scale. And the difference is in the old days where you had a single investigator working on one problem, you had one protocol, one IRB submission, one informed consent document, everybody knew what it was. That is the opposite of what biobanks are intended to do. They're intended to facilitate much research on unknown problems. So current protocol versus future protocols, individual risk benefit versus individual and group risk benefit. And the reason I say group risk benefit is because the biobank may retain demographic information, and then the study could say individuals of X, Y, Z national origin group are 7 times more likely to develop whatever. For individuals, the concern has been mostly physical harm, although sometimes social harms as well. But with biobanks, there are no physical harms. It's all these non-physical harms that are associated with biobanks. There are many issues associated with biobanks, and I think you'll be exploring many of them later, so I just don't want to spend too much time on. One is the consent to future uses. As a former IRB chair, I can tell you that IRBs are not crazy about the concept of blanket consents given to researchers to do whatever you want now and whatever you decide to do 5 years from now. One of the ways that we deal with that issue is through tiered or layered consent, where you say you can do any sort of research involving cancer with my sample, or heart disease, or you can check a bunch of things. Another issue is linkage with medical records. If you have biobank material, it's much more valuable if you can also link that with medical records. But one of the problems that you run into is you don't want extant medical records. You want extant and prospective medical records as well. And now you're asking people to give prospective consent to link their medical records, whatever they might be in the future. Now you could have someone who said, well, I've got nothing to hide or nothing I'm concerned about in my medical records today, and then next year they've got some stigmatic condition. They've got a sexually transmitted infection or mental illness or something like that, and they wouldn't be too crazy about people having access to their complete medical records. They wouldn't have given you that consent. What about the withdrawal of the sample? Well, sometimes that's hard to do, especially when the samples are commingled with others. You'd have to retain identifiers, which sometimes you don't do. Can individuals withdraw their sample from a biobank? And then the other issue is recontact. Suppose you find something that indicates that the sample source is at a much higher risk and of one thing or another, and perhaps there's some intervention that would protect them, or there's some treatment that needs to be done perhaps pre-symptomatically. what is the obligation of a researcher to recontact that individual? Maybe the individual doesn't want to be recontacted under any circumstances. Maybe you need to give that individual the option at the time they submitted the sample and say, oh, should we find something, do you want to be recontacted? I'm familiar with cases where you have somebody who is, let's say, a cancer survivor, and they say, you can have my sample on the condition that you never, ever, ever contact me again. I've mentally blocked this out, psychologically I need to put it behind me. Don't ever contact me again, no matter what you find. Well, there are other people who want to be contacted even if you don't have anything of clinical utility because they're curious. Electronic health records raise a whole range of privacy issues in genetics. At least in the United States, what we are in the process of setting up is called this network of networks, which would be interoperable, accessible, interchangeable from any location, longitudinal, cradle to grave, and comprehensive, which would include all encounters with all healthcare professionals. That would just change completely the current dynamic of our health record system. The advantages of EHRs, there are many of them. It would enhance coordination, avoid duplication, improve effectiveness in theory, improve efficiency in theory, and facilitate all sorts of research. I don't think you can be opposed to EHRs in the abstract. But one of the problems with EHRs, or one of the challenges of EHRs, it's going to destroy the number one thing that protects privacy in health information today, and that is chaos. I've lived in 10 or 12 different cities. I've probably been treated by 100 different doctors and medical practice groups. Some unknown number of those people are dead. Some unknown number of those hospitals I've been treated at are now shopping malls. If I wanted to get my hands on all my medical records, no way I could do it. That's not a good thing for continuity of care, but it's a wonderful thing for privacy. So nobody can get their hands on all my sensitive information, all my sexually transmitted infections, all my mental illnesses, my alcoholism, my drug abuse problems, the domestic violence issues, all these things that I have in my past, you can't get access to, because I can't get access to them. Now, what happens when they're accessible? If I have to sign an authorization to get a job, every prospective employer gets everything. If I want to be treated by all sorts of allied health professionals who get access to my medical record, they get access to everything unless we do something about it. So the key questions are, should patients be allowed to control access to the records? That is, who gets to see them? And then, should patients be allowed to control the content of their records? In other words, what do they get to see? I think security and confidentiality safeguards are not enough, because if you want to be treated, the healthcare provider needs your records. And if it's a third party and they have enough economic leverage over you, you're going to have to let them have access to it too. So patients, I think, are concerned about the psychic harm of having their information accessible to both healthcare providers and third parties. One of the things that we've been wrestling with in the US is, should any special protections be put in place for certain classes of sensitive information? And we haven't actually resolved that issue yet. I think we ought to have these designations, and I can talk about that later, but I've got some other stuff I want to talk about too. So the third area under new technology involves personal health records. These are patient-maintained records. Some people put, I think, too much stock in the value of personal health records. No clinician would base treatment decisions based on what a patient record contains, because they're going to include what they want, edit out things they don't want. But they're very valuable and often contain these sorts of information. I have an 86-year-old mother who visits a new doctor about once a month, and our personal health record includes 2 3x5 cards that I've put together that include her allergies and her medications. Actually, they probably ought to be on 5x8 cards, but they're still on 3x5 cards. Well, wouldn't it be nice to have a personal health record that actually had that information? Maybe that was that had some other things as well, so you wouldn't have to repeat all that information. There are 2 basic kinds of personal health records. There are freestanding PHRs, which are available through well-known vendors. And then there are what are called tethered PHRs, which are made available by the same institution that maintains your electronic health records. So that's why it's tethered, because it's related to your main file at Kaiser or Cleveland Clinic. One of the privacy issues involves the business models of these freestanding PHRs. The tethered PHRs, they're done as sort of a service to the patients and also for health purposes. If you want to start a PHR company, here's your business model options. You can charge a monthly fee, you can sell the data, or you can sell ads, pop-ups every time you log on your internet site. And because many of the services are offering them for free, the charge of the monthly fee is sort of going by the board. So now here are the way that freestanding PHRs make their money. And you can see there may be privacy issues associated with that. Other concerns, if I want to have my mother's health record on, electronically, or I want to have my own and I want to carry it around, what happens when I lose it? Now the whole world has it. Are we going to have encryption on your flash drive? And then the other concern, of course, is you might run into a well-dressed hacker who gains access to your information. Direct-to-consumer genetic testing, there are many companies that offer these services, like 23andMe, Navigenics. I'm sure you're familiar with them. And these are generally unregulated, web-based labs. And I don't want to just pick on the big 3. There are hundreds of them that are out there that will gladly offer paternity testing, genealogy testing, curiosity testing, and then the more comprehensive health risk assessments. These are home collection tests, not home performed tests. There are scientific concerns about the lack of clinical validity of the testing, lack of inter-lab concordance. So there are many studies in which you send your sample to 5 different labs and they tell you 5 different things. More common is the variance in interpretations. The labs will say you've got the same genetic findings, but the significance that attached differs. Genetic counseling is not the standard. You've got the cascade effect of genetic testing. If you do genetic testing on a big enough sample, like you do any medical test on a large enough sample, you're going to get some results that you might want to follow up. And then you're going to be following up and more tests and biopsies and all this other stuff referred to as the cascade effect. And you're, as some of us talked earlier, going to turn everybody into a full-time patient, whether they have anything wrong with them or not. Then there's the lack of clinical utility, even the accurate findings. What are you going to do with the results? And all these psychosocial harms. There's another privacy concern that I have, and that is that if you take a drink from the straw, I can sneak around, scoop up the straws, and there are many labs who will test the straw, no questions asked. No consent, no quality control, no privacy. Virtually everywhere in the United States it's legal to do that. Privacy laws do not yet apply to that kind of testing. A law was enacted in the UK several years ago that bans it, but most places do not. And there are other ethical concerns about this. There are many consumer protection issues. You've got companies engaged in selling nutrigenomics. So if you send them, the company, some buccal swabs, they will write back and say, based on our analysis, you need to be taking certain supplements, and oh, by the way, for $200 a month, we will start sending them to you. There's a lack of regulation. Certainly have the autonomy paternalism issue. People in favor of this will say, well, let consumers decide, patients, individuals decide where they want these tests. One of the things we have struggled with for many years, certainly in genetic counseling issues and clinical genetics, is a lack of public education, lack of numeracy. If you can't explain the difference between a 50% risk and a 25% risk to people in genetic counseling, how are you going to explain all these nuances? So to conclude, I called my talk this morning Reconsidering Privacy in the Genomic Era. But it's not just the genomic era, it's also the biobank era. And it's also the electronic health record era. And it's also the personal health record era. And it's also the direct-to-consumer genetic testing era. So it's not quite so simple. It's also the Patients Like Me era. And if you're not familiar with Patients Like Me, this is a website where individuals who have various conditions, not necessarily, quote, genetic, but conditions in general, voluntarily share their intimate health information with others who have the same condition, so that it's a support group, but it also facilitates research. And it demonstrates that maybe people are not so concerned about health privacy when they think there is some payout for them. So it's also the Patients Like Me era. And it's also the Facebook, MySpace, LinkedIn, and whatever today's current social networking site of interest is. So the question I have as a privacy person is, does the willingness of many individuals to share incredibly sensitive information with strangers demonstrate that we're shifting somehow in our views toward privacy? I would say no, at least not yet, but that's another long speech. But the point is that things are changing, and we need to be aware of the changes. So I think we need to reconsider on an ongoing basis what privacy is and what steps we're willing to take to protect it. Sometimes we need to take extraordinary steps. Thank you. I do have time for some questions. Yes, please. There's a microphone in the back.
And has introduced many, many of the issues we'll be dealing with today. I have two questions. The first is, are they talking to each other in those bubbles or spitting saliva at each other for testing? I'm not sure. But anyway,
that is the portable cone of silence.
Oh, is it? Okay.
Yes. There is a larger cone of silence that is just stationary, but that one travels.
So I have a basic question, and it's not just a semantic one. I think it's an important policy question. You started, and maybe it was for simplicity reasons, you classified genetic information as a subcategory of health information. But as you know, that's a hotly contested issue in and of itself, whether genetic information is a subcomponent of health information, or maybe it's the other way around. The genetic information actually includes health, but also many, a lot of non-health related information related to ancestry and other issues. So the question, as I said, is more than semantic, because as I understand, isn't that really at the root of some of the regulatory debates going on right now in the U.S. about how you handle, regulate direct-to-consumer genetic testing, for instance. Is it through the traditional medical model? Is it viewed as medical information that could be regulated that way, or are we completely looking at a broader consumer-based model for regulating these areas? So if you can comment on that.
I think the concern is how do you regulate genetic testing within at least the traditional genetic testing. I'm not talking about genealogy testing or paternity testing or maybe even cosmetic genomic testing. I mean, there are all sorts of tests. But I'm talking about the health risk assessment testing. And that is considered, I think, by all the key regulatory groups to be a kind of medical testing. And the question is, do we want to regulate it? How should it be regulated? Is it subject to the FDA's jurisdiction? Is it subject to the FTC's, the Federal Trade Commission jurisdiction? What is it that we are trying to protect? And of course, some of the issues that need to be resolved, we've already played out over the last 25 years in connection with all sorts of either home test or home collection tests. So many of you, I'm sure, remember the controversy over home collection HIV testing, right? We can't do that because we don't know who these people are. They might need to be counseled. They might have psychological problems, et cetera. We went through this with home collection hepatitis C test kits. And every time you have a test kit, the question is it going to be used accurately? Are there sufficient safeguards and so forth? So I think it's in that context as opposed to the larger definitional context of, is this a medical test? Now, if you want to start getting into the more or the less medical-based uses, let's say genealogy testing or paternity testing, now there may be slightly different interests that you need to keep in mind. But I think your point is a good one because the tests vary so much in terms of what they are purporting to test, as well as the risks that are raised for individuals. That it may mean that we need several different models of regulation and not just one.
I had a question about patient control and access to their health records and whether that really is meaningful when you have compelled disclosures. So, for example, a patient may decide to lock a certain part of the record, but then when they apply for insurance, they're compelled to consent to providing all pieces of the record, including any other parts that they may have locked for the providers, for example. And if they don't agree to that, then they're not considered good. So, does access control in that sense, is it meaningful?
Oh, that's a great question. It's sort of a second-order question, and we haven't answered the first-order questions. The first-order question is, are we going to have some sort of segmentation or sequestration of information that's set up? And clearly, there are many different kinds of healthcare providers that don't need access to one's entire record. The typical dentist filling a cavity does not need your genetic information. The typical physical therapist rehabbing your sprained ankle doesn't need access to your reproductive health history. Now, they don't have time to actually look at the stuff, but they could if they wanted to, and that's the privacy concern. Okay, so now you raise the question of what happens when I apply for a job and some of my information has been segmented and sequestered and is not accessible without additional, passwords, keys, what have you. And no one's reached that issue yet. And it depends, I would argue, on the purpose that the third party has. And so here's where we get this blend of procedural issues with the substantive issues. So in other words, what information does an employer legitimately need to have to decide whether to employ me? Now, at the moment, they can ask us, in the United States at least, they can ask to see everything except genetic information. My ideal would be that in the future, I apply for a job with a telephone company, and I want to climb telephone poles, and we have the wherewithal to punch in 3 codes that represents my job description, and electronically they will spit out all the information that's relevant to whether I have the physical and mental capacity to climb telephone poles, and that's it. So it's the opposite view. In other words, instead of taking stuff out, I'm now including certain stuff based on criteria. But we are a long way from resolving the question that you ask, and it's a very important one. What information does a life insurance company legitimately need to have? The interesting thing about if I were, designing how to address this issue, I would start with life insurance because that's the easiest case. Life insurers only need 10 or 12 different fields of information to decide whether you're low risk or high risk. And in the United States, to save money, many life insurance companies have gone to what's called tele-underwriting. The tele means telephone underwriting. If you apply for a policy below a certain amount, they'll have a nurse call you and ask you the 10 big questions. And if you give the right answers, you get the policy. If you don't give the right answers, now they're going to look into getting more of your medical information or maybe sending somebody out to examine you. So we can identify that. I mean, it's doable. We're entering a whole brave new era of electronic health records and stuff. But the privacy component is so far down the list of concerns. There are concerns about security. Everybody says, well, it's got to be secure. But very few people are focusing on the privacy issue, and that's what I tried to sort of separate out for you this morning.
Okay. I hope you were expecting this question. First of all, Mark, that was a great presentation. I don't live in the legal space, so seeing it from that perspective is always helpful. So earlier this week, maybe last week, there was a particular company that went to Chapter 11 in the U.S. Particularly, I'm talking about Decode. And so one thing I didn't hear you talking about was asset management and the extent to which what we're really talking about here is not my information, but jointly owned information, or possibly even the corporation's information, even though it is about me. And so now you have a situation in which you have a company that had lots of data on individuals, and now that they have gone out of business, it's a question of what can they do with this information. Is it an asset that they are allowed to just sell off, or is this something that the individuals that you corresponded can control? So I was hoping you could elaborate on that situation.
Yeah, well, there's no accident why I left that out, because it's very complicated legally. For those of you who want to actually look up all this stuff, about 5 years ago, Bartha Knoppers and I edited a symposium issue on biobanks, and one of the articles that we solicited was from a bankruptcy law expert, specifically thinking ahead to this kind of issue. What happens when the company goes bankrupt? Because all the promises that they make to you as a sample donor are considered contract promises, and all contracts are abrogated in bankruptcy. And the only assets that the creditors have are the samples and the information. And the trustees in bankruptcy are duty-bound to maximize the value of the estate for the creditors, which means selling off all this stuff. And that's why we specifically proposed several years ago that this is an issue that's going to come up and needs to be addressed. And we can't have this situation as I described, and that hasn't been done yet. So it's in a back issue about 5 years ago of the Journal of Law, Medicine, and Ethics, if you're interested. Yes?
Thank you very much for your talk. I greatly appreciate it. And I'd like to focus a bit on some of the values underlying, and perhaps some of the shift in some of the values that we see. I mean, certainly with respect to privacy, we privilege autonomy, and so we've seen that through Grant Rothstein and Weston. But if I look at the development of biobanks, I see the development of other values, such as altruism, reciprocity, mutuality. And I'm curious as to, in your view, with respect how the law will address those values, because individuals contribute in many cases, whether it's the Biobank or Canada, for a sense of I'll contribute my sample to help others. Yet what they are giving up in that context is not necessarily known to that human law. I'd like your views on how you see the law evolving to take into account what I see is a changing shift in our understanding of our responsibility to others within the context of healthcare delivery, but also our rights as an individual.
I thank you for that comment. That's a really terrific comment. And in one slide, I put that privacy doesn't trump other interests, and there are other important interests. And after hearing you, I would redo that slide to include all the things that you mentioned, because these are important interests to people. I included sort of societal interests like law enforcement and public health, but it is true, as you say, that people have these interests in altruism and beneficence and promoting the well-being of others, and that is an interest that needs to be respected. And so we need to allow people to give up some sense of their privacy because they think there's another interest that's more important. And the concern is that we have adequate disclosures to these individuals, and that we as researchers keep our end of the bargain. And when people donate samples and information, it needs to be scrupulously protected, and the conditions need to be set out, and we need to develop a sort of a framework in which we can make these donations easy, transparent, and effective for both sides. So I thank you for that comment. And I guess one more question.
Actually, I'll make it really quick, just to add to the decode question. I've been decoded. The note they sent me said that the data and the analysis is actually done by a subsidiary of decode, which is not in chapter 1. And that theoretically, they say that data is still protected, but there's not raw material for that subsidiary. The other thing to consider, of course, is the decode was a public company from the beginning. It was publicly traded. That data essentially was always for sale. The bankruptcy may change the circumstances, but it was a publicly traded company. So from the day that people signed up for decode, the company was always for sale, and the company was always eligible for a takeover, and the data was always up for grabs, essentially, by anybody who wanted to buy decode that. And that hasn't changed, bankruptcy or not.
Okay, well, thank you for that comment about decode. And but there are many other of these sort of startups that are maybe not in great shape, and so we need to develop policies, I think, that would protect all of them from having to sell off